Good morning, good afternoon, good evening. This is the quality improvement in the ICRR session on adapting nutritional recommendations to diverse cardiac rehab populations. And I would like to welcome everyone on behalf of Dr. Carly O'Neill, ICRR Chair, and myself, Dr. Gabriela Gysi, ICRR Chair of the User Subcommittee. I also would like to welcome all our participating centers. You can see here in this map, our centers cover all 6 WHO regions around the world, and we have 28 sites overall that participated in the ICRR. And just so you know, we have almost 7,500 patients or we have their data inputted into the ICRR. So welcome everyone. As I said, our QI session today, the topic is about adapting nutritional recommendations to diverse cardiac rehab populations. And I will be co-presenting this session with Professor Camila Kimmel. Professor Kimmel is an assistant professor at the Federal University of Minas Gerais. She is a registered dietitian with a PhD in endocrinology. She is a professor in the multi-professional residency program in cardiology at the Hospital das Clínicas at Federal University of Minas Gerais. And her areas of expertise include nutrition, diet, diabetes, cardiovascular disease, systematic review, and meta-analysis. So just a refresher why we have quality initiatives within ICRR. So these are voluntary, confidential, and non-judgmental activities, and they are designed to support your learning, not to evaluate you. So it's really a safe, friendly space for us to share some of our expertise, but also for you to share your expertise and really share what you're doing that it's working in your site, and then that may be something that other sites might find it valuable and useful. So that's a collaborative learning community. And we always invite all ICRR sites to participate, share their experiences, and learn from each other. Today it's more formal because we are having this presentation, but next week we are going to have a community of practice where simply we want you to join, and me and Camila, we are going to be there. And then simply we're just going to be having that space or that hour for a conversation and really sharing experiences. But of course, today we're going to have a period of time for Q&A where you can also ask the questions. And both the community of practice next week and the Q&A session or Q&A component of today's session will not be recorded. So again, non-judgmental, confidential. And then the final point here is that the topics are selected based on the ICRR registry data, but also from your requests. So if you struggle in some areas, or if you see there are some topics that you really wanted to get in-depth information and really hear from other sites, please email us, and we can put that for our 2026 QI sessions. Okay. So you can see here we have a website with the previous quality improvement initiatives. They are all recorded, and you can scan this QR code, or you can just go to the website. And also for each one of the sessions, there are some references and resources that you can use. So take advantage of that. And then these were the topics that were presented in 2023, 2024, and then 2025. And the reason we only had one topic in 2025 is because we were switching leadership. So there was that period of time without planning. So again, please share your ideas with us. And on that note, I would like to introduce our new QI lead, Montserrat Rivero. I'm gonna read her CV. She has joined the ICRR as the new QI lead. She's an experienced cardiac rehab physiotherapist from Mexico with extensive clinical, multidisciplinary, and leadership experience. She's a founding member of the SOMECOR, which is the Mexican Society of Cardiac Rehab, and has supported certification processes, national congresses, academic program, and institutional communications while remaining an active collaborator with ICCPR. Montserrat holds degrees in PT, so she's a physical therapist and rehab, completed a residency in cardiac rehab physiotherapy, and is pursuing a master's in exercise physiology. She's ICCPR certified, teaches at multiple academic levels, contributes to scientific publications, and frequently presents in professional and public forums. She also serves as deputy director and data steward at Casa Corazon, an ICRR participating site. Her expertise and commitment to advancing cardiac rehab quality will be available as set to ICRR. We are so pleased,
Merci.
Montserrat, to welcome you. I cannot see the screen. I cannot see the participants, but I know you are online, right? So I don't know if you want to say hi to everyone.
Yeah, don't worry, Gabriela. Thank you very much for the warm welcoming. I'm super excited to join in this new position, and thanks for Sophia and Carly that they've been guiding me step by step in this new role. And that's it. I'm super excited. I want to bring things to the table, and hopefully my position will keep advocating to improve quality in the ICRR. Thank you very much.
Thank you so much, Monserrat. I think like we are so excited to have you, and also it's great because you really know how ICRR works because you are part of one of the sites, right? So I think it's a perfect matching, and we are really excited to see you leading these sessions, moving on and working with all the sites. So that's exciting. So thanks for attending today. I know how busy you are, and thanks for again for accepting to be part of this and welcome.
Thank you. Thank you.
Good. So let's move forward with the session. This is the outline of the session today. So we are going to talk a little bit about how the nutrition is assessed at the registry. Then talking about the performance across all sites, barriers and facilitators to patients to adhere to dietary recommendations in cardiac rehab. Then I will switch to Camila, and then she will speak about the impact of a heart healthy diet, what you need to know and do to improve adherence to a heart healthy diet, how we can tailor nutritional recommendations to have a real world impact, and adapting nutrition recommendations to different cultural groups. And as I said, we're going to have a period of Q&A, and then I'm just going to really wrap up with the next steps, which is the community of practice session happening next week. So the nutrition assessment at the ICRR. So as you know, more than me, we ask our patients before and after the program. In the last month, how many servings of fruits and vegetables did you have in the average day? And they have to tell us their servings per day, and then there are some examples. And why this was chosen. This was chosen because it's simple and quick to administer. It's low burden for patients and providers. Sometimes, and again, I'm not a registered dietitian. Camila can speak a little bit more about that. But sometimes when I read scientific papers and I see like the way that the nutritional assessment happens in cardiac rehab, sometimes there is long, multiple days, frequency questionnaires. There, it's really a burden for both patients and healthcare professionals, right? Because we don't have a lot of time. So this question, it's easy to understand. There is minimal health literacy involved, and it's simple and quick. It can be comparable across programs, and that's something that it's important for us, as you know. It aligns with public health guidelines. It's good for tracking over time and less recall burden because those full dietary questionnaires where they have to remember about what they have been eating in the past week or so, it's sometimes it's hard for patients. So that's how the nutrition assessment happens in our registry. So let's talk about the performance of the sites. So most sites improve their average daily fruit and vegetable intake. So when we get the numbers or the responses of the servings for patients pre and post, there is an overall improvement across all sites of plus 1.1. So it was from 2.9 in the beginning. That's the overall for all the sites. 2.9 servings in the beginning to 4 servings per day. And then we have 8 sites with minimal or no change. So 8 sites, they change around 0 to 0.1. 3 sites with substantial improvements. So more than 2 to more than 4.7 servings per day. And then 2 sites showed a small decrease in intake. And then 6 sites with zero value. So 6 sites indicate this show us that they did not ask their patients and there is no reported intake or maybe no reported intake or maybe a missing data. And then I just want to highlight those 3 sites. Sir H. N. Reliance Foundation Hospital in India, the Take Heart in Sanish, BC, so in British Columbia, Canada, and the University of Thessaly, I hope I'm pronouncing correctly, in Greece. Those are the highest performing sites. And what I mean by that is that they have more patients close to reaching the guideline targets, which are 5 or more servings of fruits and vegetables per day. And they also demonstrate consistent documentation of the nutrition question. So they have fewer missing and incomplete responses. So let's talk about barriers to adherence to the dietary recommendations in cardiac rehab. And the reason I am, as a PT and scientist, talking about this is because I've been doing lots of studies assessing barriers to nutritional recommendations in cardiac rehab and really trying to understand how we can really support this important piece in cardiac rehab, right? So the barriers are multi-level. So they're not just on patients, right? So we tend to say that patients are busy, they have financial reasons, and they don't have time and they don't understand that this is always true this is true as you can see here, right? So there's socioeconomic status, it's a big thing for patients. There's personal reasons like motivation, preferences, the psychological piece. It's very important in this context, social pressures. But we cannot forget that there's also other layers of that barrier, of those barriers, right? There's other domains. So there's system environmental barriers. So there's lack of family support. Sometimes, and I see this here often, the woman, or let's say it's a male participant that is coming to cardiac rehab, and then he learns about the healthy eating, but then he's not the one cooking at home. So and then maybe there is no really change in the way that the food is prepared. Poor availability of healthy foods and social environment challenges. It's big. And the example for social environment challenges can even be, it's related also to socioeconomic factors, but it can also be like sometimes the fresh fruits and vegetables and healthy foods, they are not available as well. And then also the multi-level barriers, so knowledge gaps, language limitations, social situations. So there's many factors that affect how patients eat and adhere to this dietary recommendations they receive in our programs. But also we can think about facilitators as well. So there's studies showing, and this is all this content is based on a systematic review and meta-analysis that I've done a couple of years ago. So older age was a facilitator because we saw in the studies that younger people they had multitasking, multiple responsibilities, and it was hard for them to to take the time and prepare the food, the healthy food, because sometimes it takes more time. Another facilitator is supportive financial circumstances. For instance, if the elderly, let's just use again its example, if the elderly lives with the family and they eat healthy, so that's another facilitator. So, ongoing support and encouragement from the cardiac rehab team was considered a facilitator. And again, this is based on both slides, both barriers and facilitators that I'm presenting. It's based on this review, so it's evidence based. And then clear nutrition education and reassurance. So patient education, it's also a facilitator. If as part of your program, you do deliver education and then you have nutrition counseling and nutrition sessions on how to eat healthy, that's again also a facilitator for patients to adhere to those recommendations. And then family support can be so the no support can be a barrier and family support can be a facilitator, like shared changes, meal preparation, encouragement, and knowledge and their understanding of diet, and then how diet can be linked to cardiovascular diseases. It's also a facilitator having that understanding. And then, of course, the literature shows other barriers and facilitators like competing priorities, as I said, the work, childcare, caregiving, marketing, and food environment. We know some countries still advertise some fatty food as fancy and all those things and fun. So that can also influence seasonality, impacting availability of fresh food. Now here in Canada it's winter, and I do know that in some areas it's hard to find some fresh foods. Acculturation challenges for immigrant groups is a big thing. Misconceptions about dietary recommendations, lack of standardized nutrition interventions across cardiac rehab programs. These are all barriers. And as facilitators, including culturally tailored education into your nutrition sessions. Because just going back again to acculturation, sometimes when you move from one country to another, it's hard at the beginning to find the spices and the seasoning and the way that you prepare the healthy food in your country. So that takes time. So maybe bringing those things into your education, if you do live in a country that is multicultural, I think it's very important. Peer support, it's super important. Not only having those sessions with your patients, maybe one-on-one, but including a group of people and providing time for them to share what it's working for them can really support other patients. Providing accessible tools, the use of virtual education resources. We know our time with the patients is limited, so guiding patients and directing them to online resources where they can really learn at their own time and pace. It's very important. And some practical skills training. If you can provide cooking demos, teach them how to read labels, maybe some grocery tours. I think there's a fun and hands-on and great ways that patients can learn about how important eating healthy is for their health. Okay, so let's move to Camila. Camila, it's up to you.
Yes. Thank you, Gabriela. First, I'd like to say hi to everyone, and it's a great pleasure to be here. Thank you for the invite. And as Gabriela mentioned earlier, we'll talk a little bit now about what is a heart healthy diet and what you need to know, and I too, and what we need to do to improve the adherence to a heart healthy diet in our programs. And also, I will talk about how to tailor nutritional recommendations on the real world. This study, I will talk about a study that Gabriela and I just performed. We are finishing this study, the MAPCR. And also, we will finishing talking about adapting the nutritional recommendations to different cultural groups. Gabriela? Yeah. So first, we need to try to understand what is a heart-healthy diet. When we talk about diet, most people think that diet is a very restrictive eating pattern. But when we talk about a heart-healthy diet, we need to understand that it's a dietary pattern that focuses on reducing the intake of saturated fat, sodium, and simple carbohydrates, and increasing fruits and vegetables, nuts, legumes, and healthy diet. It's not a very restrictive dietary pattern, but a dietary pattern that focuses on what can help you to prevent disease and to have to improve your quality of life. So we have some very known examples that almost all guidelines recommend. That is the Mediterranean diet, the DASH diet, and the portfolio diet. They are already structured to help us on how to perform the nutritional counseling for heart healthy for patients, for cardiovascular patients, and to improve the diet to be a heart healthy diet. As probably all of you know, nutritional counseling is one of the components of of a comprehensive cardiovascular rehabilitation program, and we need to improve this area. You can pass, Gabriela, please. Yeah, thank you. We need to first remember that for cardiovascular patients, following nutritional recommendation is a lifeline. It's not just a suggestion, because when they achieve a heart healthy diet, we know that they can prevent so much complications on the cardiac disease. And we know by the literature that patients that do not complete a comprehensive cardiac rehab program that includes nutritional counseling, they present almost 70% risk of having a new heart event. So the nutritional counseling is a very important component of a good and comprehensive cardiac rehab program, and we need to focus on that, not just on the other parts of the cardiac rehab program, like the exercise and the psychological aspects, but also what our patients are eating. And as you probably know, the Mediterranean diet is a very recommended dietary pattern for prevention of cardiac disease and also on how to treat the patients with cardiovascular disease. And so many studies have shown this on the last decades. One of the very known one is the first one that I'm sitting here, that is the Lion Diet Heart Study, that show us that following the Mediterranean diet can prevent cardiac death and myocardial infarction around 70%. It's a lot. So the diet can really improve your cardiovascular health. But also, so many other dietary patterns are linked to better cardiovascular outcomes. And more recently, we have been focusing on trying to understand the role of a plant-based diet pattern on the cardiovascular health. And we already know that in the recent years, like the Eat and the Lancet pattern that was released by the Lancet journal, focusing on a study on how following the plant-based diet can reduce the risk of non-fatal vascular events and reduce the risk of strokes. But sometimes we think that, okay, following and recommending a dietary pattern is very complex because the patient needs to change so many things and needs to improve and take out so many like harmful type of foods. But we know that doing small changes, it will already improve so much the quality of life of our patients. we have a lot of data showing that increasing fruits and vegetables in the whole population, the general population, it can increase the quality of life of individuals, especially the physical component, the physical health component of the quality of life. And the World Health Organization recommends a minimum of 400 grams of fruits and vegetables a day to prevent disease in general. But we also know, like the ICRR evaluated, as Gabriela mentioned, that fruits and vegetables are it's one of the main components of a heart healthy diet, and they should be the base of a healthy diet. And some of you may know there's a campaign that it started in the early 80s in the USA that we call it the 5-a-day. Maybe you already heard about it. And what is the 5-a-day? It's a campaign that it stimulates the patients to eat 5 fruits and vegetables per day. Maybe you think, oh, it's too much, 5 a day. It's so difficult. My patients don't eat not even one portion of fruit or vegetable in a day. But as you can see on the right side of our slides, it's not that it's not big portions. So 80 grams of a fresh or canned fruits, it's just one portion. And even you can recommend the patients to drink a natural juice or even smoothies. And maybe if he doesn't like to eat so many fruits, prefers the vegetables or even legumes, you can recommend it like 80 grams of beans. It's not that much in the day. So it's a good strategy on how to improve the quality of the diet and also on how to make it more heart healthy. And what are the benefits of eating more fruits and vegetables? We have so many benefits with this, and we have some stated on the cardiovascular health, like reducing the risk of developing cardiovascular disease in general, around 15%, and also reducing the risk of complications and developing new heart disease, like the coronary heart disease or having a stroke, and even reducing death risks around 27%. And it's not that complex. It's to make your patients to recommend it to increase the intake of fruits and vegetables. It's a very small strategy comparing on the big chains of a whole dietary pattern. And this, as you can see, have so many benefits for the patients. Now I would like to share some experience from Brazil, and I will start talking a little bit about some data that we have that was recently released. In Brazil, we have a study named Vigitel that represents it's a sample of the whole population that is interviewed. And this study, unfortunately, said to us that only 34% of Brazilians eat at least one fruit or a vegetable during 5 days of a week. As probably all of you know, Brazil is a tropical country. We have so many fruits and vegetables. It's not easy to find on every areas. We have some, like we say, desert and swamp areas for food, but it's much more easy than in some countries. However, as Gabriela mentioned early, one of the main barriers that we see in one of our projects here in Brazil to buy healthy fruits is the food price. And we know that this is not an issue that only Brazil presents. We have so many countries with this same barrier facing the same barrier to buy healthy fruits. And as you can see on this data, on the recent years, the cost of fruits and vegetables in Brazil increased, and it continues to be a big issue. We have fruits, but it's not so easy to buy them, and we don't have the adequate income to buy it. But we need to remember that fresh fruits are not the only option. We have so many formats of fruits available, fruits and vegetables available. And we have canned options, as Gabriela mentioned, she's in the winter and it's not so easy to have fresh foods when you're in the middle of snow. And maybe in some other areas of the globe, we have some heat waves, and this is making fresh foods more costly and not so available. So we need to remember that we have another options, and those options can also be healthy options to eat fruits and vegetables, like the canned ones, the frozen ones, or even juice. And we need to also remember that these different forms present different costs. Like this is an example of United States, and as you can see on the middle of this slide, that fresh foods are cheaper than canned options, but also juice, natural juice, frozen, like apple frozen concentrates, they are cheaper than the fresh ones. So we have another options on how to offer vegetables and fruits for patients. But how to start? How to overcome all of those barriers that Gabriela mentioned early to improve the nutritional adherence of our patients? And I would like to start saying that we need to know our patients. We need to listen to them. We need to understand what are the challenges they are facing, understand on what context they are they are in, and what are their food traditions, what is important for him, what he wants to continue eating, and it's important for him. It's something that gives him pleasure, like food traditions, like dishes that are important to his family. And also try to understand what are their preferences. If he doesn't like a special dish, maybe you can offer another option. You can try to find nutritious substitutes. So you need to know your patient. And also, as I mentioned, the financial situation is very important. For example, here we recommend a lot the Mediterranean diet, but olive oil in Brazil, it's very expensive. It's not an easy product to recommend for all of the patients. So we need to know what he is willing to buy. Okay, he has the money to buy olive oil. So nice, good. But if he doesn't have, what we are going to do, what we are going to offer, we need to work with this situation and still help the patient to improve their health, their diet. And also, start with small changes. Don't start by talking about big changes and changing the whole dietary pattern. This probably will make your patient go away and don't come back to talk with you and to build the diet and the dietary pattern with you. Encourage the gradual and small changes. And what we want is the long-term healthy habits. We want our patients to follow the diet for the rest of his life. As I mentioned, it's a lifeline for a cardiac patient. So don't focus on restricting what is unhealthy. Maybe if you try to offer him nutritious food and recommended what he likes and what is his preference that are healthy options, this will come automatically. The patient will stop eating what is not so healthy, or maybe it will not even eat anymore. So focus on what is good for health and what will bring benefits rather than judging what he's eating and saying to him that, no, you shouldn't eat that. Focus on what the patient should eat. Also work with the patient on how to modify the recipes. If he likes a special dish that is deep fried, maybe you can try with him another option that it's baked in the oven or it's boiled. Maybe we can try another recipes and adjust the cooking methods. Is a nice way on how to maintain the flavors and the combinations, but using a much more healthy technique. And find nutritious substitutes. For example, if your patient doesn't like beans, you can try to find another substitute. Beans are not the only plant-based diet, plant-based protein source. You can have chickpeas and seeds and nuts. They also have so many other nutrients and protein, plant-based protein. So we can try to adjust according to the patient's preference, but we need to know what are our patient's preferences. And also, I would like to share about the dietary guideline for the Brazilian population. Some experience from our center. This is a national guideline that we use a lot in our cardiac program here in Belo Horizonte. And they have a very nice strategy that we call it the gold rule. This strategy helps the patient on how to choose what is healthy, what is the healthiest option. So here you can see the natural food is a corn. It's an example of a corn. And it's very common to find corn in Brazil. It's not that cheap and it's healthy. It has fibers and carbohydrates and so many other minerals. They are so good for your health. But sometimes corn, it's a seasonal produce. So maybe in some months of the year, it's not so easy to find. It's more expensive if you find, and sometimes not so tasty because it's not the season, the right season to buy corn. And we have another option that we call it the processed food, the yellow one in the middle of the slide. So the processed options are a good option and can be healthy too, but we need to help our patients how to choose the processed options, like the ones without salt and sugar added, can be as healthy as the first one. So it's another option. It's not so costly when it's not the season of the corn, the fresh corn, and you can buy this almost every area of Brazil. But also, this guideline reinforces a very special type of food that we need to have attention is the ultra processed foods, and why we need to help our patients to understand this is not a very healthy option, because processed foods, it's corn, okay, it's corn and salt, okay, but already they also have so many additives like emulsifiers and flavorings and colorings, and this is linked to the the incidence of new diseases. So this is a very good strategy that you can use with your patients. And it's not exclusive from the Brazilian dietary guideline, but it's a very simple way here, if you never heard about it, on how to do this recommendation. You can visualize it very differently. Also, one of the recommendations that we need to focus and we need to have attention is on the local availability and the affordability of foods. So when you talk to your patient, try to understand the food environment when he is inside, and where he lives, and what it's in around his neighborhood. Maybe you can help him to find the best place to buy fresh foods and more nutritious foods. So we recommended like the local farmers, or even try to find community gardens, or even maybe he can have your patient can try to plant something in his house if you have some small spaces. Sometimes we have this around us. We need to find it. So even when the patient is buying in community, it's taking food from community gardens and trying to buy from local food markets. Usually he is improving his health, but also he is improving this community knowledge that local farmers have this offering to help you, and it's improving the local business also. So it's a nice way to have fresh fruits and to increase this type of products. And try to understand your patient is one of the main messages that I would like to say to you. But also teach your patient and try to reach them when you are speaking. So try to use simple language, empathetic language, and explain why this is beneficial for him. So why this food is better than the other option, why this will help your cardiovascular health. So one strategy is like giving cooking classes to the patients to show them that it's not so difficult to cook, and maybe he will discover that he's very good in it. And maybe you don't have the space, or even you don't have money to do this because it will be costly. But we have some technology tools to use, like cooking classes videos that are free on the internet and are very healthy. And this will make cooking more close to your patients. Also, work together on building the meal planning. So don't let this by the patient itself. Don't give a list of what to eat, and he needs to work on how to make all together, and how to buy, and where to buy it, and how much of this type of food should I buy. So use what we have around us, like the technology and the artificial intelligence, if you have around you, to help to build the meal planning with your patients. This will will help the patient on how to make better options, to choose better options for the week, and this will make him more close to a heart healthy diet. And remember that part of the enjoyment of eating is choosing healthy foods that reflect your preference. And for most of us, our preference and eating habits come from our cultures and our family backgrounds and food traditions. So when you put culture and food traditions in the prescription of the patient, this will probably make him feel more confident on how to choose this healthy diet, this heart healthy diet, and it will probably make it easier to follow it. And why should we integrate cultural aspects to nutritional recommendations? Probably it will make the patient feel more pleasure while eating when he's choosing foods that he enjoys. Also, maybe he will try to do the dishes, the family tradition dishes, and will grow their skills and knowledge about food. And also, maybe the patient will start to connect with their food traditions. Maybe he's moved from a city, he's sitting in another country, and they don't have, like Gabriela told early, they don't have the spices and all of the foods that it's usually common in its culture. But now maybe with encouragement, it will make him learn more, read about it, and try to reconnect with their cultural background, and understanding that this can be a very heart healthy option. Another example from the Brazilian food guide, that if you know a little bit about Brazilian food and Brazilian dishes, these are all very known foods in Brazil. Almost all areas of Brazil are using this type of food, like the fresh foods that you see, and tapioca and beans and rice. This is so common in Brazil. It's so strongly linked with our culture. And the Brazilian guideline, makes some suggestions on how to do your dishes. The first part of this slide is the breakfast, and the second part is an example of lunch, but using cultural food that it's very known by everyone, and they are also healthy options to add to your dietary pattern. So the guideline recommends that you do not take off the foods that are important for you and that are tasting, that make you feel better, and that are easy to find in your area. But you need to structure your plate with a lot of type of foods that will make this probably a more healthy option for you. And remember that in many cultures, for Brazilians, this is it's a reality. Food and food traditions are central in celebrations. So Brazilians like to party, for example, as a lot of other cultures, and food is usually one of the ways that we use to celebrate and to share. And the table is a place of sharing. And also the Mediterranean diet focus so much on the social aspects that we need to share food and eat with others. Usually we say with the family, but sometimes the family can be a barrier, as Gabriela mentioned it, but with friends and neighbors and everyone that you have around. So food is a moment of eating, is a moment of sharing, and it's a big part of how we connect to others, and it's a celebration moment. So now I will talk about the MAP-CR, that is the Mediterranean Diet Adaptation Priorities for Cardiac Rehabilitation, is a recent study that Gabriela and we are finishing to perform this study. We are the main investigators, but we had the help of other dietitians from Canada too. And this is a project funded by the Canadian Institute of Health Research, the CIHR, and our main focus was to try to identify priorities and cultural relevance adaptations for the Mediterranean diet when used with diverse cardiovascular rehabilitation populations, like in Brazil, like in Canada, and other parts of the world. Just briefly, what we did on this study. First, we started listening to dietitians from Canada and from Brazil. And why those countries? Because Brazil is a mostly low recom in-source setting. So we had the experience to listen to dietitians that are out of the Mediterranean area and that are prescribing the Mediterranean diet to cardiac patients, but they have a very important barriers to overcome, especially the food price, as mentioned earlier. And in Canada, it's a place with more financial resource. However, we have Toronto is a multicultural city. So we had the experience to listen to dietitians that give recommendations to patients with so many different backgrounds, like Asians and Europeans and Africans and Latin American patients. So how we heard about them on how they use the Mediterranean diet to prescribe in cardiac rehabilitation programs, and how they add the cultural background of each patient on the prescriptions, how they use the main dishes that the patient likes, and how they adapt this to the Mediterranean style. And also, we had the privilege to listen to patients from Canada. As I mentioned, Toronto is a multicultural city, so our patients were from so many different backgrounds, and we heard about them, what they think about the Mediterranean diet, how they think this type of diet helps them to follow a heart healthy diet, and if their cultural background is also assessed when they are receiving dietary recommendations, if the health professionals are helping them to maintain their food traditions and their culture when prescribing the Mediterranean diet to them. And at the end of this part of the focus groups, we had a list of, if I don't remember well the exact number, it's around 26, not making any mistakes, 26 recommendations on how to adapt the Mediterranean diet to cardiac rehabilitation patients. And this list was evaluated by in a Delphine panel of specialists, including dietitians, physical therapists, and maybe you had the pleasure and to evaluate this list to us. And now we are working at the final list of recommendations on how to adapt the Mediterranean diet. And we think that with the results of this project, we will help so many centers and patients and professionals on how to do this, and also on how to maintain the cultural backgrounds and food traditions of our patients following a heart healthy diet. So, as I mentioned, we are just finishing this, and probably very soon we will have all of these suggestions on how to adapt the Mediterranean diet. It will be available in 6 languages, and we will have the opportunity to read it, and probably you will receive this list very soon. I have some key take-home messages for you to summarize everything that we said earlier. So the adherence to the dietary recommendations in cardiac rehabilitation program is shaped by a range of individual and cultural and socioeconomic factors, as we mentioned, like the culture, the family, the incomes, and everything else. And we need to remember all of this when we are prescribing to our patients, and that many of those barriers that we identify, they are modifiable. So this is a good news. We can try to overcome those barriers with tailored education, practical strategies, and ongoing support. And also, culturally sensitive and patient-centered approach will help more and can improve relevance, motivation, and long-term behavior change. Our main focus is this, the long-term behavior change, so patient can learn what is heart healthy and follow it through his whole life. It's a lifeline, as I mentioned it earlier. In raising access to affordable, healthy foods and addressing structural challenges remain essential to support heart healthy eating. We need, as a group of health professionals and people that study cardiovascular disease, we need to work together to help this, but also we need politics that will help to improve the access to heart healthy foods. It's not just nutritional recommendations. We need to change what is in our food environment. So these are our take-home messages. Hope you like it.
And as I said, we will have another opportunity to, as a group, share our challenges, ask questions to Camila, and that will be our community of practice happening next week, December 16, 8 to 9 a.m. Eastern Time. And it's open to all of you. And again, it's confidential, not judgmental. It's not going to be recorded. It's just an opportunity for us to talk a little bit more on this important topic. And we really hope that you are available and can join me and Camila to talk more about diet in cardiac rehab, or let's say heart healthy eating pattern. Let's not talk about diet, right? And just a reminder that there were some training sessions on QI. So the first video, it shows the ICRR features for quality assessment. And the second one, it's a really short and good one on the value and process of quality improvement. So why all of those activities and opportunities for you to talk and share. It's just so important, right? But that really provides a structured presentation on why QI is important. And of course, let's stay connected, follow us on social media, and also connect with Sophia through the ICRR email or our generic ICCPR email. If you have something to share about your program, we are always happy to feature you in our social media channels as well as the insider newsletter. So these are our emails, mine, Camila's, and the ICRR one. If you have any specific questions, you can email us, but please join next week's session. And we have also a list of references, and I will put all those references into with the recording of this session. So if you want to go back, or if you want to read more about what me and Camila presented, here are the references, and you can have that list. We will share with you. Okay? Thank you so much. I hope you find this session valuable, and we hope to see you next week.
Thank you. Bye bye.